Aloha, and welcome to HMSA's webinar on Medicare Risk Adjustment. Before we get started, I'd like to mention that HMSA has a few more webinars planned for this year. On October 19th, we'll have our annual Medicare Advantage provider training. We have some very exciting changes coming to our Medicare Advantage plans, so be sure to join us for this event. Scheduled for November 9th is our fourth and final Quest integration webinar for 2022. We'll also be having a payment transformation update webinar in late November or early December. Once we get the date confirmed, we'll send out a flyer. In today's webinar, we'll be talking about some of the basics of risk adjustment, RAF scores, hierarchical condition categories, and diagnosis mapping. We'll look at substance use disorders, and we'll also look at ways to improve your documentation, which will help with more accurate coding of your patient's conditions. Let's start off with some background on risk adjustment. What is it, why we need it, and how risk adjustment is used? There are many ways to describe risk adjustment, but to sum it up, it's a method that's used to pay health plans based on the demographics and health status of Medicare beneficiaries. Accurate risk adjustment payments reflect the degree of illness of each patient. This in turn allows the Centers for Medicare and Medicaid Services to make appropriate payments to health plans and estimate future spending for beneficiaries. It also enables providers to understand the health characteristics of their managed population. CMS calculates these payments by using an individualized risk adjustment or RAF score for each patient. The hierarchical condition category risk adjustment model consists of over 72,000 ICD-10 codes, of which more than 9,800 are codes associated with higher expected costs of care. These codes are arranged into 19 categories and spread out over 86 different condition categories. The risk adjustment model is used by CMS to estimate predicted costs for Medicare Advantage beneficiaries. The results of this model have a direct impact on the reimbursement received by healthcare organizations, and subsequently, that in turn impacts payments to physicians. The HCC risk adjustment model has been in use since 2004, and over the years it's become increasingly prevalent as value-based payment models gain popularity. HCC codes represent costly chronic health conditions as well as some severe acute conditions. The HCC model assigns a risk adjustment factor to each Medicare beneficiary as a measurement of probable future costs. The RAF score is used to adjust capitation payments for beneficiaries enrolled in Medicare Advantage plans. Hierarchical condition category coding helps communicate the patient's complexity and paint a picture of the patient as a whole. Accurate HCC coding and risk adjustment can have a significant impact on a healthcare organization's financial viability and care delivery. When we talk about HCC coding and RAF scores, we're talking about your ICD-10 diagnosis coding. The physician needs to have proper documentation and submit claims with proper ICD-10 codes. Medicare then takes the data submitted on your claim and assigns the appropriate HCC code. To help understand how the risk adjustment model works, here's a summary of the characteristics of the CMS HCC models. The models consider serious manifestations of a condition rather than all levels of severity of a condition, and it includes most body systems and conditions. The patient's condition in the model are additive, meaning a patient's individual risk score is calculated by adding the coefficients associated with each patient's demographic and disease factors. The models are also prospective in nature, meaning they use diagnostic information from a base year to predict costs for the following year. They're also site neutral and don't distinguish payment based on a site of care. The models recognize diagnoses that are submitted on claims from hospital inpatient and outpatient settings, as well as physician settings. Risk-adjusted payment is based on assignment of diagnoses to disease groups, also known as condition categories. The model is most heavily influenced by Medicare costs associated with chronic disease. Condition categories are placed into hierarchies, reflecting severity and cost dominance. Beneficiaries get credit for the disease with the highest severity or that subsumes the cost of other diseases. Hierarchies allow for payment based on the most serious conditions when less serious conditions also exist. This assures that the more advanced and costly forms of a condition are reflected in the risk score of the beneficiary. Disease interactions allow for higher risk scores for certain conditions when the presence of another disease or demographic status is indicative of higher cost. Disease interactions are also additive factors and increase payment accuracy. Models also include 5 demographic factors, which are typically measured as of the data collection period. The 5 demographic factors include the beneficiary's age as of February 1st of the benefit year, their gender. Disabled status results in the inclusion of additional factors in the risk scores of community residents who are disabled beneficiaries under 65 years of age. The original reason for Medicare entitlement results in the inclusion of a factor in the risk score for beneficiaries 65 years of age or older who were originally entitled to Medicare due to a disability, and it also factors in Medicaid or low-income status. There are many ways a patient's RAF score can be affected. If a patient has a low RAF score, it could mean they're a healthy patient, which would be great. However, there could be other reasons for the low score. If there is insufficient documentation in the medical record, your biller may be unable to properly code and bill your claim, resulting in unreported or underreported diagnoses. Documentation linked to a nonspecific diagnosis as well as incomplete documentation also has a negative impact on reimbursement. Inaccurate diagnosis coding can also lower a patient's RAF score. If the document states the patient has diabetes with complications, but the claim is billed with E11.9, type 2 diabetes mellitus without complications, this will result in a lower RAF score since diabetes without complications falls into a different HCC with a lower coefficient. Another reason a patient may have a lower RAF score could be due to simply not being seen by a physician annually. In this scenario, they may have unreported conditions that, if addressed, would contribute to increasing the patient's RAF score. Patients with a higher RAF score are likely to have chronic conditions, which take more resources to treat. However, sometimes claims get billed with diagnoses that were not actually documented in the record, or they were documented but without enough specificity to properly code for the diagnosis. Then the coder may have inferred the more severe diagnosis. Another reason for a higher RAF score could be due to overcoding, and this happens when copying and pasting the problem list into the assessment or plan in your EMR. These types of errors could be found during an audit, so you could do a self-audit to head off these types of errors. As an overview of the risk adjustment process, we start with the demographic factors for age, gender, disease interactions, and Medicaid eligibility. The coefficients for each eligible diagnosis is added to this base amount. This gives us the patient's risk adjustment factor. The diagnosis codes submitted on claims are what drives a patient's RAF scores. The RAF score determines the reimbursement from CMS to the Medicare Advantage organization. If the proper documentation is found to be missing, CMS would do a take-back. This is how accurate documentation helps the MAO retain reimbursement from CMS, and that reimbursement is passed on to providers via their reimbursement. Inaccurate or inconsistent documentation can leave you exposed to a much higher level of financial risk. There are certain things to keep in mind when you're thinking about risk adjustment. CMS requires an encounter each calendar year to confirm the diagnosis of a patient's condition. These diagnoses must be made by an APRN, physician assistant, or physician. Remember, the patient's risk score is reset each year at the beginning of the year. Scores start at 0 on January 1st of each year, so each existing diagnosis will need to be re-added and properly documented. Essentially, in the eyes of CMS, limbs grow back, ostomies close, and any condition that's not cured needs to be restated and documented in order for it to be recaptured. Medical record documentation must be accurate and support the diagnosis being reported on your claim. Without accurate and complete documentation, a condition might not be counted, which would result in a lower score. While all diagnosis codes are mapped to a condition category, not all condition categories are included in the model used in payment. The decision to include a condition category in the model is based on each category's ability to predict costs for Medicare Parts A and B benefits. Condition categories that don't predict costs well are not included in the model. The majority of the codes included are chronic condition codes, but there are some acute conditions that risk adjust. HCC codes are additive, so if your patient has more than one chronic illness, the risk adjustment factors for each eligible condition are added together, and this will result in a higher risk score. Your patient's risk score enables you to easily identify and risk stratify your patient panel for more effective patient management. Your claims data is what impacts chronic condition reporting. There are many conditions that may have an additive effect on risk adjustment. Anytime diagnoses which are identified as risk adjusting conditions are on your claim, they'll have an additive value to the patient's risk adjustment score. The conditions shown here are just some of the many conditions that risk adjust. The top HCC categories include major depressive and bipolar disorders, asthma and pulmonary disease, diabetes, specified heart arrhythmias, congestive heart failure, breast and prostate cancer, and rheumatoid arthritis. Some CMS HCCs belong to families that are subject to hierarchy elimination. If providers report multiple conditions that map to a family in a single calendar year for a patient, only the HCC representing the most severe condition is used for risk score calculation. If an ICD-10 code is submitted for a patient during a calendar year and it maps to an HCC shown in the first column of this chart, and diseases were also reported for that patient in any HCC listed in the right-hand column of the same row, then all the HCCs in the last or right-hand column are dropped and not used in the HCC risk score calculation. Only the HCC in the first column is calculated. For example, if HCC 8 applies to a patient, then Medicare will not use HCCs 9, 10, 11, and 12 in the risk score calculation. HCCs are called hierarchical because certain conditions within a related category or family may have notable severity differences. The highest severity in the family will trump or take precedence over any less severe conditions within that family. Diabetes is a good example to illustrate hierarchy. A patient diagnosed with diabetic ketoacidosis would be an HCC 17 versus a patient diagnosed with diabetes without complications, they would be an HCC 19 category, with HCC 17 being the more severe diagnosis. A patient may see multiple providers throughout the year, with each submitting a claim for service. Not all providers document the details of a condition the exact same way, which may result in the hierarchical system coming into play. Only the HCC value of the most severe condition in the hierarchy would be used for risk score calculation for that member. In another example, if Medicare received a claim in February for diabetes without complication, and another claim was submitted in September for the same member for diabetes with a chronic complication of peripheral vascular disease, only the risk value of the more severe HCC would be used in the HCC risk score calculation for that beneficiary. Medicare risk adjustment uses the CMS HCC crosswalk to calculate a member's annual risk score based on chronic and severe acute conditions that are expected to impact healthcare costs long term. Each HCC is a collection of similar diagnoses in one payment group. For example, shown here, we have 3 conditions listed that are all coded with different ICD-10 codes. Unspecified pulmonary hypertension is I-27.20, chronic diastolic heart failure, I-50.32, and dilated cardiomyopathy, I-42.0. However, even though they have different ICD-10 codes, all 3 of these diagnoses map to the same HCC, which is HCC 85, congestive heart failure. Regardless of how many times a patient's diagnosis codes map to a single HCC, the risk value or factor for that category is added only once to a patient's risk score each year. I mentioned earlier that the model is additive. If a provider submits other diagnoses outside of a family of codes at any time in a calendar year, Medicare also uses those diagnoses when calculating the patient's HCC risk score. In this example, in the chart on the left, we have a patient who's been diagnosed with 2 different alcohol dependence diagnoses, other specified mood disorder, paranoid schizophrenia, and type 2 diabetes without complications. Each of these 5 diagnoses map to an HCC as you see listed in this chart. Now, if you look at the chart on the right-hand side, you'll see that this patient has multiple HCC scores added together for HCCs 54, 57, and 19, but no additive factors for HCCs 55 or 59 is used in this calculation. This is because the HCC 54 takes precedence over or trumps HCC 55, and HCC 57 takes precedence over HCC 59. The precedence is due to the increased severity of these diagnoses. The information about hierarchies is presented to show you how the calculations and hierarchy groupings are performed by CMS. Remember, you won't have to do any of these calculations, but seeing how risk scores are calculated is helpful to fully understand the need for accurate and complete diagnosis reporting. Here we have another risk adjustment example. The numbers shown here are strictly for illustration. As you see in the first chart on the left, we have information that the beneficiary is a 76-year-old female who is Medicaid eligible and has been diagnosed with peripheral vascular disease. Her diabetes and congestive heart failure have not been properly documented and coded, and this results in a RAF score of 0.886. In the middle table, you have the same beneficiary, and we have both of her peripheral vascular disease and diabetes documented and coded, and this raises her RAF score a little higher to 1.004. Now looking at the third table on the right, we have the same beneficiary with all of her conditions addressed. We have coding for her peripheral vascular disease, her diabetes, and congestive heart failure, as well as documentation of the disease interaction between her diabetes and congestive heart failure. This results in the maximum eligible score, which is nearly double of what was presented in the first chart. If a diagnosis is left undocumented or coded, the score does not depict the true severity of illness for that patient. This is where we want to be. We want to have all present conditions coded for all patients. This will illustrate the most accurate picture of your patient's health, as well as the amount of care needed for the patient and the amount of your work effort expended in managing your patient's health. Today, I wanted to talk a little bit about substance use disorder, since it is one of the newer HCC categories. The DSM-5 recognizes that people are not all automatically or equally vulnerable to developing substance-related disorders. Some people have lower levels of self-control that predispose them to develop problems if exposed to drugs. According to the DSM-5, substance use disorder occurs when a person's use of alcohol or another substance leads to health issues or problems at work, school, or home. The term substance use refers to the use of drugs or alcohol and includes substances such as cigarettes, illegal drugs, prescription drugs, inhalants, and solvents. A substance use problem occurs when using alcohol or other drugs causes harm to self or others, and substance use can lead to addiction. The DSM-5 manual advises the diagnosis of a substance use disorder is based on a pathological pattern of behavior related to the use of the substance, such as using the substance for longer than intended, or a persistent desire to cut down or regulate the substance use, or multiple unsuccessful attempts to decrease or discontinue use. In total, the DSM-5 outlines 11 specific criteria for diagnosing a substance use disorder and allows clinicians to specify the severity of the disorder. This would be mild when 2 to 3 criteria are met, moderate when the patient meets 4 to 5 of the criteria, and severe if 6 or more of the criteria are met. Mental health problems and substance use disorders sometimes coexist for the following reasons. Mental health problems and substance use disorders share some underlying causes. Some people with mental health problems may turn to substance use to self-medicate. And use of certain substances can cause people with addiction to experience mental health issues or have substance-induced disorders. The signs and symptoms of substance use are variable, depending on the particular substance being used. Some signs or examples of substance use include slurred speech, enlarged liver, mild tremors, needle marks, nasal irritation, dilated or small pinpoint pupils, an alcohol odor on their breath, or marijuana odor on their clothing. For substance use disorders, your supporting documentation should include the substance, start date of use, the quantity, frequency of use, and specify if there is abuse or dependence. A person may abuse drugs or alcohol, but not be dependent on them. The provider must clearly document the condition. Also document signs of physical damage caused by the abuse or dependence, such as liver damage or weight loss. Substance use disorders, like anxiety, depression, and sleep disorders, span a wide variety of problems arising from substance use and cover 11 different criteria. The 11 criteria outlined in the DSM-5 can be grouped into 4 primary categories: physical dependence, risky use, social problems, and impaired control. The 11 criteria include taking the substance in larger amounts or for longer than you're meant to, wanting to cut down or stop using the substance but not managing to, spending a lot of time acquiring, using, or recovering from use of the substance, cravings and urges to use the substance, not managing to do what you should at work, home, or school because of substance use, continuing to use even when it causes problems in the relationships, giving up important social, occupational, or recreational activities because of substance use, using substances again and again, even when it puts you in danger, continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance, needing more of the substance to get the effect you want, or developing an increased tolerance to the substance. Development of withdrawal symptoms, which can be relieved by taking more of the substance. In your documentation, use additional codes to identify the presence of alcohol use, abuse, or dependence, including in remission. Document tobacco use or dependence, including history of use, as well as any hypertension. The DSM-5 allows clinicians to specify how severe the substance use disorder is, depending on how many symptoms are identified. The clinician can also add in words such as in early remission, in sustained remission, on maintenance therapy for certain substances, and in a controlled environment. These further describe the current state of the substance use disorder. Understanding the severity of a substance use disorder can help doctors and therapists better determine which treatments to recommend. Choosing the appropriate level of care may improve a person's chances of recovery. Risk adjustment is all about specificity. When documenting substance use disorders, avoid vague diagnosis descriptions such as other or unspecified. Document each condition to the highest level of specificity, including as appropriate if the patient is in remission, and if that remission is partial or full, early or sustained. Document the specific substance involved and whether there is use versus abuse versus dependence. Document all related symptoms and conditions such as with intoxication, psychotic behavior, sleep disturbance, or withdrawal. When the patient is being followed and managed by another provider for their substance use disorder, it's still appropriate to include the diagnosis in the final assessment. Anytime that condition has an impact on patient care, care treatment and management. For example, you could document opioid dependence in sustained remission per records from the treating psychiatrist, Dr. Kekoa. Substance use disorders are classified in Chapter 5, Mental, Behavioral, and Neurodevelopmental Disorders, in Section 2 under Substance-Related and Addictive Disorders. And this is in the DSM-5 manual. Always report the most specific code the medical record supports. Remember to code the alcohol or drug use with any alcoholic or drug-induced disorders, such as anxiety, depression, sleep disorder, or opioid use with sleep disorder, if applicable. Selection of codes for in remission requires the provider's clinical judgment. Your coders are not allowed to clinically interpret documented timeframes to decide that the condition is in remission. The appropriate codes for in remission are assigned only on the basis of specific provider's documentation unless otherwise instructed by the classification or if the coding path leads to remission. Mild substance use disorders in early or sustained remission are classified to the appropriate codes for substance abuse in remission, which is the F19 category. Moderate or severe substance use disorders in early or sustained remission are classified to the appropriate codes for substance dependence in remission. And just to clarify, substance use is any consumption of alcohol or drugs. Something as commonplace as having a drink with friends during dinner is considered substance use. Substance use may not be a problem or even lead to abuse or dependency in some people. Substance abuse is when someone continues to use drugs or alcohol, even when it causes problems such as trouble with work, family, or their health. For instance, continuing to use drugs, knowing you'll be fired if you fail a drug test, is a sign of abuse. Substance dependence is an addiction to alcohol or drugs. You may be unable to stop drinking or using drugs and have physical withdrawal symptoms when you try to quit. Be sure you're documenting these correctly. These are the root codes for substance use, abuse, and dependence. Be sure to use each code to the highest level of specificity, indicating any remission status or associated disorders or complications. Now let's take a look at how we can improve documentation for risk adjustment. When paying Medicare Advantage organizations, CMS takes the plan base per member per month payment and multiplies that by the factors for a clinically complex patient. The more risk-adjusted conditions a patient has, the more multipliers there will be for that patient because it's an additive model. The base PMPM is multiplied by the coefficient for each risk-adjusted condition. When there's proper documentation of treatment for the complex needs patient and proper coding, this results in more equitable funding to the MAO to support high-risk medical resource utilization. And then on the other end of the spectrum, when documentation and coding are incomplete and not to the highest level of specificity, this equates to reduced funding to the MAO. And this has a trickle-down effect, which eventually affects provider reimbursement. There are many ways you can improve your risk adjustment scores. And by improve, what I really mean is just to make them more accurate. Many provider offices have been using EMRs for many years, and this results in a lot of data and possibly inaccurate problem lists for some patients. You want to be sure to remove any duplicative and any inactive diagnoses. Review your patient panel to identify those patients with chronic diseases. Then identify those patients with chronic conditions who haven't yet been seen during the calendar year. This is really important because you need to code every active condition each year. The provider will need to submit diagnosis codes to let Medicare know the patient has a condition, even if they've had that same condition for the past 10 or 20 years. Once you've identified these patients, contact the patient and schedule a visit. Identify future opportunities for improvement by reviewing any unresolved persistent conditions. What we're looking for is accuracy. You don't want to code a condition that may have already been resolved. So again, be sure to see your patient at least once each year. Identify and review any unresolved and persistent conditions. Medical record documentation of patient diagnoses that is clear, concise, and described to the highest level of specificity leads to quality patient care with better outcomes, accurate diagnosis code assignment, and appropriate and timely health care provider payment for furnished services. The importance of consistent and complete documentation in the medical record cannot be overemphasized. You can improve your risk adjustment by improving your documentation. Proper documentation allows for your biller and coder to accurately bill for services you're providing. Make sure your notes clearly link the plan and the disease. Problem lists without an assessment or plan cannot be coded. Be sure your notes support medical necessity. Notes must validate the services you've provided and are submitting claims for. Your documentation should be able to ensure continuity of care for the patient. Documentation should verify the services you've provided are reported accurately. And remember, medical records are legal documents. When you're documenting, be sure it's done in a way that can be easily understood by other professionals who may need to review it at a future date. Your documentation should adhere to the MEAT principles. For monitoring, documentation of signs, symptoms, disease progression, regression, ongoing surveillance of a chronic condition, ordering of tests, or sending referrals. For evaluation, just listing the diagnosis isn't enough information. There must be evaluation. The medical record must thoroughly document all conditions evaluated. Evaluative documentation would include documentation of the current state of a chronic condition, physical exam findings, test results, medication effectiveness, or response to treatment. Listing medications and prescriptions in a medical record does not meet your documentation requirements to indicate that an evaluation for a condition was performed. A diagnosis must be in the medical record progress note along with an evaluation in order to fully meet documentation requirements. For assessment, some examples would be documentation of discussion of chronic conditions, review of records, counseling, how the chronic condition will be evaluated, status of the condition, and further ordering of tests. Documentation for treatment could include documenting the care being offered, prescribing or continuation of medications, referral to a specialist, ordering diagnostic studies, therapies or other modalities, or a plan for the management of a chronic condition. Plans can be simple, such as monitor condition, refer, continue current meds, control diet or exercise, or better compliance. Your progress notes or SOAP notes document the patient's medical status. These notes should be concise in stating the reason for the visit, and the notes should be consistent with the patient's visit. Notes should also be entered in a timely manner. Ensure your notes are complete and include any conclusions, screenings, and follow-ups. Your notes should also be logical in supporting the MEET principles. Documentation should indicate the diagnoses are being managed, evaluated, assessed, or addressed, and treated. You must have an assessment and plan for each diagnosis using simple language. Be sure to authenticate your notes with your signature and credentials, as well as have the provider's name and date on each page of the progress note. Also, ensure you have the patient's name, date of birth, and date of service on each page of the assessment. Be sure to use the highest degree of specificity and assign the most precise ICD-10 code to fully explain the narrative description of the symptom or diagnosis in the medical chart. You need details in your record to code to the highest level of specificity, which may include laterality and acuity. Whenever possible, avoid a lack of specificity, such as documenting an unspecified arrhythmia rather than the specific type of arrhythmia. Progress note documentation should be a clear record of each clinical diagnosis to the greatest degree of certainty and specificity for every encounter. Don't forget any complications or manifestations, including any causal notations. Document all conditions which have been confirmed. Remember to review consult notes and discharge summaries as well. Abnormal findings are not coded from lab or radiology results unless clinical significance is documented in the record by the provider. Also ensure each patient has an assessment of all chronic conditions at least once every year so you can accurately reflect the work effort expended on that patient. Be sure you're documenting any chronic conditions as chronic. Some conditions that are commonly documented without being noted as chronic are hepatitis and renal insufficiency. For patients with cancer, document the status of the patient's cancer as well as all treatment related to the cancer. You'll want to be sure the diagnosis codes being billed and the actual written description in the medical records align. If the record indicates depression not otherwise specified, but the diagnosis code written on the encounter claim is for major depression, These codes do not match. They map to different HCC categories. The diagnosis code and the description in the record should mirror each other. Avoid using the term history of if the patient is still being monitored for the condition. For example, you'd avoid documenting something like patient has a history of diabetes and instead note something more specific such as patient has type 2 diabetes mellitus with ketoacidosis. History of means the patient is cured, not being treated, and has no clinical evidence of the disease. History of is acceptable when you're documenting status conditions such as amputation status, transplant status, dialysis or chemotherapy status, or artificial opening status or maintenance. Documentation should include complete assessments of the patient noting any chronic condition that affects the care and or treatment of that patient on that date of service. Many chronic conditions that have an impact on risk adjustment are often underdocumented. Here are some examples where documentation improvement could be applied. Rather than just noting that the patient has diabetes, be sure to indicate type 1 or type 2 and if there are any complications. This is important because there are times when conditions default to a particular diagnosis, as in the case with diabetes. If it's not specified as type 2, your coder will have to have it default to type 1. Instead of noting the patient has chronic kidney disease, indicate what stage of the disease the patient has. If the patient has heart failure, but also has hypertensive CKD, document the stage of the CKD along with noting that it's with heart failure. Commonly, a provider will document COPD, but could be more specific in saying the patient has COPD exacerbation or COPD with infection. For BMI, just noting the patient's BMI alone will not risk adjust no matter what their BMI is. The BMI could be 40, but the effort involved in caring for the patient may not be compensated equitably unless you're documenting the words morbid obesity along with the patient's BMI. Then your coder can submit code E66.01. This is particularly important because you can code morbid obesity even with a BMI that is not greater than 40. The assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. Just noting major depressive disorder will not affect a patient's RAF score, but by specifying the episode and the severity, then the condition will risk adjust. Bronchitis that is unspecified as to acute or chronic will not risk adjust, but if it's documented as chronic bronchitis, it does risk adjust, so be sure to specify when dealing with bronchitis. When demonstrating causal relationships with diseases, explicitly state in the medical documentation a cause and effect relationship between chronic conditions and any associated manifestations. Specify the causal relationship by using words such as due to, with or associated with, complicated by, or secondary to. For example, a patient seen for type 2 diabetes with advanced diabetes and renal manifestations caused by diabetes, that would be diabetic nephropathy. To show a causal relationship, the physician should note labs and urine tests results and document diabetic nephropathy or nephropathy due to diabetes mellitus. If either of the following is documented, then the highest specificity code would be captured, so diabetic nephropathy or CKD stage 3 due to diabetes. Remember, if a causal relationship is not clearly indicated in the progress notes, the conditions will be coded separately and the highest specificity code will be missed. A condition only exists when it's documented in the medical record. Diagnoses do not carry over from visit to visit or year to year, so you will need to document each condition every year. A condition can be coded and reported as many times as the patient receives care and treatment for the condition. Describe the condition in words. Just notating the ICD-10 code for a condition isn't sufficient for proper documentation. Conditions can be coded when the document states the condition is being monitored and treated by a specialist, such as you could notate patient on Xarelto for atrial fibrillation, followed by Dr. Keikoa. Coexisting conditions can be coded when the documentation states the condition affects the care, treatment, or management of the patient. For example, documenting autistic patient comes in for chronic constipation. Document and code status conditions at least once a year. These would be those status conditions we just talked about: amputation, transplant, dialysis, chemotherapy, and artificial opening status. Do not code any unconfirmed diagnoses. Avoid coding conditions when the documentation states probable, possible, suspected, or working diagnosis. And avoid the use of arrows or symbols alone in your documentation to indicate diagnoses such as for cholesterol levels or hypertension. In response to the COVID-19 pandemic, CMS has released guidelines regarding risk adjustment data submissions for telehealth services. Medicare Advantage organizations such as HMSA and other organizations that submit diagnoses for risk adjusted payments continue to be able to submit diagnoses for risk adjustment that are from telehealth visits when those visits meet all criteria for risk adjustment eligibility. This includes allowable inpatient, outpatient, or professional services, as well as face-to-face encounters. Diagnoses resulting from telehealth services continue to meet the risk adjustment face-to-face requirement when the services are provided using interactive audio telecommunication simultaneously with video telecommunication to permit real-time interactive communication with the beneficiary. In other words, you're most likely using a video call service similar to Skype or Doximity. There are many different companies out there offering this type of service. A best practice tip when documenting your telehealth visit is to add an attestation statement to the medical record indicating the total time for the visit and that it was conducted using two-way audio and video. This is a requirement for telehealth visits. Providers have the ability to improve their performance by focusing on ensuring they have accurate and complete documentation on the health conditions of their Medicare Advantage populations. Here are some opportunities you can use to increase performance. Verify that all patients are scheduled for visits and that all of their risk adjustable conditions are documented. Annual wellness visits can help to ensure comprehensive recapture of chronic as well as newly acquired or diagnosed risk adjustable conditions. This is important since it's likely that you have patients who have not had a provider visit due to the pandemic, and it's a perfect opportunity to address all of your patients' conditions. Utilize telehealth for those patients reluctant to or unable to come into the office. If you review your patient panel and identify those who haven't had a visit yet this year, a telehealth visit may help you close their gaps in care. Ensure that the new HCC conditions added by the Cures Act are captured, especially those for patients with chronic kidney disease, dementia, pressure ulcers, and substance use. These conditions may not show up as gaps in care as they may not have been captured in the past. Risk stratify your patient panel and prioritize your patients that likely have 3 or more chronic conditions. Schedule visits and do chart reviews for these patients to ensure all conditions are captured. When documenting, avoid rule outs. Do not diagnose conditions with rule out or suspected diagnoses, but diagnose those conditions with the highest level of certainty for that patient visit. Use test results. The result of a test can be used to confirm a diagnosis only if the physician writes a progress note that interprets the test and makes a diagnosis. Support the diagnosis. It's not enough to state that the patient has a particular diagnosis. There should be evidence in the medical record to support that diagnosis. Review your EMR problem list and ensure they are accurate and not carrying over any conditions that have already resolved. CMS requires an encounter each calendar year and diagnosis by an APRN, PA, or physician. And lastly, review the patient's RCCs. They'll need to be confirmed or disconfirmed each year. Medical coding of patient encounters is only as good as the underlying medical record documentation. Here are some commonly overlooked diagnoses that risk adjust. If you aren't already documenting these annually, now is a great time to start. Artificial openings, amputations. Remember, Medicare needs to be told each year when a patient has an amputation. HIV status, organ transplant, myocardial infarction, obesity, paraplegia, quadriplegia, and renal dialysis. Other conditions often overlooked include rheumatoid arthritis, vascular disease, major depression, malnutrition, and bowel obstruction. Also recall that there are many complications that come along with diabetes. Some that you may unintentionally overlook include skin conditions, periodontal disease, and other oral complications. Today we have some information to share with you on improving CMS encounter acceptance. Claims submitted to HMSA may not be accepted by CMS when sent as encounters. Information on your claim that's unrelated to reimbursement may prevent the entire encounter from being accepted. Here are some tips to ensure your encounters are accepted at CMS. For professional claims, ensure the referring provider NPI is valid in the National NPI Registry, and ensure that the referring provider NPI is a type 1 for an individual and not a type 2 for an organization. We have been seeing encounter errors mostly related to the referring provider NPI not being an individual or valid reference on NPPES. Over half of the encounters that we've seen for this error had a referring provider NPI for Hawaii Emergency Physician Association, which is a type 2 NPI. We've also had a handful of other professional claims reflect the payee's practice NPI and not the individual physician's NPI. For facility claims, we are seeing similar issues for attending provider NPI. For example, a facility submitting a claim as an FQHC, but using the facility NPI as the attending provider NPI for claims like venipuncture. Be sure you're billing with the attending provider's individual NPI. Another tip to improve your CMS encounter claims acceptance is when you're making corrections to the place of service for professional and type of bill for facility claims, we're asking that providers address these types of corrections as void, then submit a new claim rather than an adjustment claim. And this is a little bit different than the process you're probably currently used to. And lastly today, just a reminder regarding multi-language insert. HMSA does have free interpreter services to answer any questions you may have about our health or drug plan. To get an interpreter, just call us at 1-800-660-4672. Someone who speaks your requested language can help you. This is a free service. We have this available in 15 languages. In addition to English, it is available in Arabic, Cantonese, Mandarin, French, French Creole, German, Hindi, Italian, Japanese, Korean, Polish, Portuguese, Russian, Spanish, Tagalog, and Vietnamese. And this is a list of materials requiring the multi-language insert that is applicable to healthcare providers. And here we have some acronyms that you'll probably have seen through today's presentation or that apply to risk adjustment. Thank you for joining us today. We look forward to seeing you at future HMSA educational sessions.